Well, good morning. It's wonderful to be here with you again. I think some of you, I don't know if some of you have been here, had it before when we were over in the Oto Clinic, and this is a much better format. I think the stadium seating, lots of room. This will be a much more pleasant conference for you. And as Rich said, I'm a neurotologist, ENT doctor, specializing in E. And so I'll kind of go through the evaluation and a little bit of thoughts about some of the ways that we might treat tinnitus. So for the most part, the vast majority of cases of tinnitus, we don't know what the cause of it is. That's one of the purposes of this conference, and a lot of the research that many of you might do is to try and figure that out. But in most cases, it's associated with damage somewhere in the auditory system. There's usually evidence of damage somewhere in the auditory system that's associated with the perception of tinnitus. That could be within the cochlea. It could be what we call retrocochlear pathology, be it the auditory nerve or higher centers of the brain. Sometimes a head associated with head injury. And it's actually pretty uncommon. It can happen, but it's pretty rare to have tinnitus occurring when people have normal hearing. Am I getting an echo because both mics are on? Okay, it sounded funny. And so it's almost always associated with some sort of pathology in the ear. And because of that, medical evaluation is rarely negative. We usually are able to find some things that are wrong. And it's important to realize that very rarely, tinnitus can be an early symptom of something that's serious. And again, just to highlight that usually it's accompanied by hearing loss. And so why does a patient seek medical attention for tinnitus? Not everybody does. In fact, many of them don't, and they'll do Google searches, or they'll just talk to their colleagues, or they'll just assume it's normal and things like that. But those who come in for medical attention, some of them are coming in just to know what's going on. What's causing this? I've got this funny sound, what's going on? Some come in because they're concerned that it may represent something serious. Do I have a brain tumor, is their question often. And then some come in because they hope to get relief from it. It bothers them enough that they're hoping to find something that they can do about it to get it to go away or to improve. You want me to talk into this? No, just do both, okay. And so why is an otolaryngologist or another physician, how is that helpful in the workup or the management of tinnitus? One is that they should be able to help you exclude any serious illness. So we'll go through that. The times when we suspect that there could be something more going on and we need to look further, and I'll go through those kind of cases. Sometimes there's a treatable cause for hearing loss, not often, but sometimes there's a treatable cause, and so that's helpful to know. And then sometimes it's just reassuring to the patient to know that they've been evaluated, that things have been looked at, and that everything is not normal, but everything's as it should be. So how is it that we evaluate patients that come in and complaining of tinnitus? And for the most part, all we do is these first three things. We get a thorough history, perform a physical examination, and 99.9% of the time we'll order an audiogram. Less commonly, we use imaging studies, and we base our decision on whether or not to get imaging studies based on the results of these first three sort of factors. So what are the key sort of elements when we're talking to the patient that we're trying to figure out? Well, one of the important things is what's it like? Is this sort of a high-pitched tone? Is it something like that? Is it bilateral? Is it unilateral? Is it a pulsatile, clicking, popping, clicking? Is it a roar like in low-frequency hearing loss you might see in Meniere's disease? When did it start? How long has it been going on? Is it something that waxes and wanes? Is it constant? Those sort of things. Really important, is it in one ear or both ears? That's a critical thing, at least for us in our algorithm of how much we're going to worry about this. Things that can exacerbate or relieve it, whether they perceive any hearing loss. It's interesting, tinnitus is often the first symptom that they have of hearing loss. They have evidence of hearing loss, but they're not aware of it unless their spouse is dragging them in. Sometimes they're not aware of what's going on. Is it associated with vertigo? Are there other cranial nerve abnormalities, and in particular, numbness of the face or weakness of the face, double vision, hoarseness, swallowing problems, indicative of it's often associated with pulsatile tinnitus. Are they exposed to loud noises, or do they have a remote history even of noise exposure? Were they in the military or someplace like that? Look at their medications. Sometimes medications can be exacerbated. It's amazing. One of the problems that we face is, of course, if you look at the labels of almost every medication, they'll say dizziness and sometimes tinnitus. Those are just common symptoms of just about anything. And so it's really sometimes hard to sort out whether the medication is really causing a role. But the patients expect you to look at that. It's an important thing. And there are some that can contribute or exacerbate tinnitus. And then it's really important to sort of figure out if sort of their overlying hearing loss is fitting in a pattern that's typical of their family, and then also to sort of assess whether there's mental or psychiatric stressors, exacerbators, or underlying disease that's either affecting how they perceive their tinnitus or affecting how they deal with it, or things like that. So then the things that we look at when we examine the patient, obviously we look in their ear, look for any evidence of middle ear or tympanic membrane pathology. Tuning forks, Weber is a really sensitive test for conductive hearing loss, and then a thorough sort of cranial nerve exam. And those are the most important things. There's other things we do. If they have pulsatile tinnitus, we'll be listening for bruits or some other things like that. If they have clicking or popping, we may be looking at their palate to see if they have contraction of their palatal muscles or things like that. But for the most part, these are the most important elements of the physical examination. And like I say, if they have clicking or popping, we'll often do a fiber optic examination of the nasopharynx. So we have little telescopes so you can pass through their nose and look at their eustachian tube and the soft palate and see if there's any myoclonus or contraction of the muscles around the palate or the eustachian tube. If they have pulsatile tinnitus, we'll listen with stethoscopes to around the ear, as well as in their neck. We'll occlude the jugular vein, see if that exacerbates or relieves it. And then the other thing we can do is we have these stethoscopes where you can put it in their ear and then put it in your ear, and you can see if you can hear what they're listening to. And sometimes you can do that, and that would be evidence of objective tinnitus. So it's not common, but especially with pulsatile tinnitus and even some other forms, you can actually hear what they're hearing. And then, so what about the hearing test? What are sort of the important things that we look at when the patient's main complaint is tinnitus? Well, we want to know, do they have a hearing loss? If they have hearing loss, is it conductive or sensory neural or mixed? And then very important is we want to see if there's symmetry, because one of the algorithms that I'll lead you down depends on whether there's unilateral hearing loss or unilateral tinnitus. Look at their speech discrimination score. These things not only impact sort of the tinnitus and how you might manage it, whether you're going to fit them with hearing aids or some other things, and how those might be helpful. The pattern of hearing loss is also key. People with low-frequency hearing loss, such as is seen in Meniere's disease, typically have a different character of tinnitus than those who have high-frequency hearing loss. People with noise-induced hearing loss frequently have tinnitus. It's a very, very common. I'd say noise causes tinnitus more often than other types of pathology in the ear. And I think Dr. Stephen Green's going to talk a little bit about some of the molecular things that may be contributing to that. And then you just sort of want to get a gestalt of whether their hearing test sort of jives with everything else. Is their hearing test consistent with their history that they've been telling you, and is it consistent with their physical examination? So when do we worry, or when do we say, well, we need to look into this further? This isn't just sort of run-of-the-mill tinnitus. If they have persistent, so it's not uncommon for people to have temporary transient tinnitus in one ear or both ears. And if it's really temporary and really transient, we don't get too worried about it. But if it's persistent, if it's going on, and even if it's not there all the time, but it's frequently there and it's been going on for several months, then we then we start to worry. And so any unilateral symptoms, whether it's tinnitus with or without hearing loss, so asymmetry on the hearing loss, then we want to look for retrocochlear pathology. And the gold standard is to screen with an MRI. Sometimes in older patients where we're sort of mildly concerned, but if we were to miss a small, acoustic neuroma that was quite small, we'd watch it anyway. It's reasonable to get an ABR in those patients because even if you found the tumor, you may not do anything about it. And the ABR is actually quite good for picking up the bigger tumors that you need to know about, and it would only miss the smaller ones. So in an older patient where you're not too concerned about making sure you've picked up the smallest of small tumors, and an ABR is sufficient. For the most part, the MRI is the gold standard. And then if anyone has cranial neuropathies, meaning hoarseness, their vocal cord is paralyzed, swallowing trouble from having palatal problems, they have facial numbness, diplopia, double vision, facial weakness, something like that, then you either need to get an MRI or a temporal bone CT based on the rest of the exam. If you see a middle ear mass and you're thinking it might be a glomus tumor, you're probably going to start with the temporal bone CT, but you're really going to end up getting both the MRI and the CT scan. And so often in these cases, they're getting an MRI with or without a CT scan. Other sort of things that we look at. So if people have pulsatile tinnitus, then the recommendation, the sort of gold standard, is to look at their vasculature going to their head. So we can do that now in one of several ways. You can get so MRI uses magnets to sort of image, and they can image the blood vessels, so that would be called an MRA, arteriogram, MRV, venogram. So you can use both arterial and venous phases and look at their vasculature using the MRI machine. You can also do a pretty good job with, especially with arterial phases of things, with CAT scans. So you can do a CTA, meaning a CT angiogram. It's far, far, far less common now to do true angiograms, unless you've picked up a pathology on these other non-invasive studies. So in the older days, 15, 20 years ago, you may have done some sort of diagnostic angiograms looking for something. But now with these new sequences of MRA and CT, that's almost always what we'll use. They're more than sensitive enough, and they spare the patient the potential problems of having an angiogram. It's a good idea to get a neuro-ophthalmologic exam if these other things are negative. There's a syndrome called benign intracranial hypertension I'll talk a little bit about, and those patients can have pressure on their optic nerve, and so it's good to have the eye examined. And in combination with that, if there is suspicion of increased intracranial pressure or the pseudotumoral cerebri, then you may need to do a lumbar puncture to help to diagnose that. And so these are all things that we look at. The reason that we're getting the MRA, the MRV, is to look at for vascular problems. Usually those will be these arterial venous fistulas, or a vascular tumor, or an arterial venous malformation. And like I mentioned before, there's this syndrome that's becoming, in some ways, it's almost becoming epidemic if you look at the trend. So as the obesity epidemic is coming on, one of the associated problems with obesity, and this is particularly true for some reason in sort of middle-aged women, is that they develop this intracranial hypertension where they have higher pressures on their brain. That's otherwise not causing problems, but it can put pressure on the optic nerve, and they can have vision problems. It can erode the skull base, and they can develop spinal fluid leaks. And just having that extra pressure sometimes gives them pulsatile tinnitus. So what are the most common things that we see in patients who have, or that we diagnose them with in addition to their tinnitus? By far and away, the biggest thing is just a genetically determined progressive sensory neural hearing loss. And I use that term for a reason, rather than just saying age-related or presbycusis, because people lose hearing at different rates and at different ages. It's a lot like me losing hair or someone else. Some men start losing their hair in their 20s, some in their 40s, some in their 60s, and by the time they're 80, most men have thinned their hair, but the extent and the rate, the age at which that starts, the extent to which it happens is largely genetically determined. And that's true of hearing loss. Hearing loss, some people in their 80s have really good hearing, some in their 40s are starting to lose their hearing. It's an age-related process, but really the underlying thing is probably some genetically determined factors that sort of predispose them to losing hearing sooner or later than others. So that would be by far and away the most common cause. Noise, again, is a very common cause of hearing loss, and especially of tinnitus. Head injury, much less. There's just, if it happens, it can be a problem, but it's not that common that we see head injuries causing problems unless it's severe. Ototoxic medications are actually fairly rare, I would say, but there's some that I'll highlight in a few minutes. A conductive hearing loss for a variety of reasons. Conductive hearing loss really isn't necessarily a diagnosis, it's a finding and part of a symptom, but for whatever reason, otosclerosis, a cholesteatoma, middle ear trauma, perforated eardrum, chronic ear disease, any of those things that cause a conductive hearing loss can certainly lead to tinnitus. Meniere's disease, my experience, Meniere's disease is way overdiagnosed. You get someone going to see their family practice doctor with a little bit of dizziness and maybe some tinnitus, and they get diagnosed with Meniere's disease, and it really isn't. But almost everybody with Meniere's disease certainly has tinnitus. It's extremely rare to see a patient with Meniere's disease that doesn't have tinnitus. And of course, it's a unilateral disease, so their tinnitus is much different and much more prominent in one ear versus the other. Vestibular schwannomas are a rare cause of tinnitus. I'll go into that later. Glomus tumors, either jugulare or tympanicum, are also rare tumors, even more rare than a vestibular schwannoma, but would be a common cause for a pulsatile tinnitus. So less common problems, these usually have more to do with pulsatile tinnitus. I already talked to you about this benign or idiopathic intracranial hypertension, or pseudotumor cerebri is another diagnosis for that. Again, it's not a problem in and of itself usually, but it's becoming much, much more prevalent. Actually, more common than I put it here, a high jugular bulb is often associated with it. We don't know if it's causal or not. In the old days, people used to even go in and occlude it, and now even in the last 3 or 4 years, there's been a few papers published where people have gone in and sort of, if they had a high jugular bulb, tried to compress it down or something like that. It's in my opinion, you'd only do that in the most extreme circumstance after everything else that you've tried has failed. You can have an aberrant or deformed carotid artery. Maybe there could be a little aneurysm on it. That's a rare cause. The one that we worry about is a dural AVM or AVF. This is where what we mean by an arterial venous fistula is that I'll show you some images of it, but basically when your blood, it starts in an artery and it normally then flows from big arteries down to small, tiny little arteries or arterioles, and then into a very small capillary bed, and then perfuses the tissues, and then it collects into a bigger and bigger venous system. So it goes from a large artery down to a much smaller thing, into a tissue bed of very small blood vessels or capillaries, and then it recollects back up. But you can have the situation where an artery and a vein are in continuity with each other for whatever reason, trauma or a malformation, and so you're having this high pressure blood flow that's coming from an arterial system and then directly entering into a venous system, which is not set up for high pressure flow or high pressure to receive it's set up to receive blood that's gone through this capillary bed and has a low pressure system. So it shunts a lot of blood through there, and those are at high risk of bleeding and a significant bleed. There was a senator from South Dakota who had that problem. Palatal myoclonus, again, is just this contraction that can either be of the palate or the middle ear, where you just have this spasmodic contraction of the muscles, so they start to spasm. And people can hear that. So again, back to this genetically determined sensory neural hearing loss or presbycusis. This is bilateral, it should be, and so they'll typically have bilateral high-pitched tinnitus because it typically affects the base of the cochlea. And this is, we just base this diagnosis on their history, their examination, their audiogram. It's all pretty typical. You've seen many of these. And this is a vast majority of patients with tinnitus, and there's not much further evaluation that needs to be done for those patients. So what about medicines that cause hearing loss? This is something that gets a lot of press. People come in and ask about it. They're on aspirin because they have a stent or a heart problem or something like that. Is my aspirin causing it? Aspirin has to be taken in very, very high doses to cause tinnitus, very high doses. Nobody who's on like a daily aspirin is taking enough aspirin to cause tinnitus, and their aspirin is not exacerbating it. Further, the tinnitus and the hearing loss that's caused by aspirin is reversible. So it affects the stria vascularis. So in fact, in the old days, the rheumatologists used to tell their patients, their rheumatoid arthritis patients or someone, that they were using these sort of high-dose aspirin as an anti-inflammatory thing. Take it until you hear tinnitus, and then we know your blood levels are high enough. And they were taking high doses of aspirin, and then when they came off their aspirin, it would do it. Quinine is not used much anymore. This is a rarely used medication nowadays. This is 30, 40 years ago that people were using quinine. Diuretics can cause hearing loss and thereby cause tinnitus, especially combined with aminoglycosides. So if someone, for some reason, it doesn't happen very often anymore, but if someone's getting intravenous aminoglycosides to treat a severe infection and they are also getting a diuretic, especially these loop diuretics, then that can potentially exacerbate the hearing loss that the aminoglycosides might cause. Erythromycin, vancomycin really probably aren't much of a contributor. Vancomycin used to be recognized as a pretty ototoxic medication, but it turns out it was more the carrier, the drug, or the stuff that they were preparing the drug in, more than it was the vancomycin itself. And so we don't see near as much vancomycin ototoxicity as we used to. Cisplatin and other platinum-based chemotherapeutics always cause hearing loss, almost always. It's almost rare that you see a patient who doesn't have a high-frequency hearing loss if they've been on some of these chemotherapeutics, the platinum-based ones. And they're relatively common use. They're relatively effective. And they're often used in combination with radiation. So if they have a head and neck cancer, they're getting radiation plus this chemotherapy, then they're probably going to have a hearing loss. And it can be pretty significant. Again, it's high frequency, but you can sort of explain to the patient that the tinnitus lets you know you're alive. I mean, it's sort of one of the things that indicates vitality, because if without that, you might, without the chemotherapy, you might be dead. I don't know how many of you seen patients who have Vicodin. So most of you are now aware that currently, but this actually started 20, 25 years ago, there's been a dramatic increase in the percent of patients who take narcotics. And especially in the Hollywood sort of culture. There's this vitamin V, Vicodin, and they take narcotics. They use it for chronic pain. They get on it. And so that's why you see a lot of these, movie stars, rock stars or whatever, who are, dying from narcotic overdoses. But recognize, this is probably now 20, 25 years ago, was recognized that this particular combination of narcotics with Tylenol is toxic to the ear. And the character is, these are the typical scenario is you have a patient who's taking Vicodin or a similarly concocted mixture of a narcotic and Tylenol, and they usually are taking on the order of 15 to 20 pills a day, and they've been doing it for several years, 7, 10, 15 years. And then all of a sudden, within a matter of 2 or 3 days, they go profoundly deaf. Sudden, dramatic, bilateral, profound hearing loss. And so it's not something that comes up on them gradually. I actually think it's probably the acetaminophen, not the narcotic, that's causing the problem. Nobody takes 20 Tylenol pills a day on a chronic basis. If people take acute Tylenol overdose, then they get liver toxicity. It has a specific toxicity, but nobody just takes 20 Tylenols a day for 10, 15, 20 years. You don't have that motivation. The problem with the narcotics is you take them and your body develops a tolerance, and so you take more and more and more, and so you escalate your dose over the years. You're also, because it's combined with acetaminophen, you're also escalating your Tylenol dose. We don't know for sure, but the studies that do exist or suggest it might be the acetaminophen in these combinations. But either way, dramatic, profound, bilateral sensorineural hearing loss. This is sort of the Rush Limbaugh deafness syndrome. So conductive hearing loss, you want to know if it's unilateral, bilateral. It's common. It's very, very, very common for people with conductive hearing loss to have a pulse synchronous tinnitus. They hear the pounding. I just saw a patient Tuesday who, I can't remember the scenario, but they were so relieved that when we had, whatever we had done to fix their hearing loss, that it took away their pulse synchronous tinnitus. And these, of course, the diagnosis is made on the examination as well as a hearing test. And common causes, chronic otitis media or otitis media, otosclerosis, trauma, cholesteatoma, sometimes simple things like cerumen impaction. And we just treat the underlying pathology in most of these patients. Meniere's disease, again, they have a very characteristic tinnitus, which is this low-pitched roaring. It's different than the high-pitched humming or tones or things that people describe. They describe a seashell type tinnitus in their ear, or a car engine type tinnitus. And the fullness that they get and the tinnitus exacerbates significantly right in conjunction with their vertigo spell. So they can sometimes tell you, yeah, my ear starts to roar and I know I'm going to get my vertigo attack and I have to go, lay down or do something like that. And the other problem is the tinnitus will frequently persist even if you're able to control their vertigo attack. So with Meniere's disease, we have pretty good ways of getting rid of their vertigo attacks, whether it's medication, diets, or surgery, but we're not very successful at treating their hearing loss or their tinnitus. Acoustic neuromas or vestibular schwannomas, the most common symptom of the most common initial symptom of a vestibular schwannoma is unilateral tinnitus. So that's why we worry about patients with unilateral tinnitus. And then they typically have this slowly progressive hearing loss. Their discrimination score is usually disproportionately poor compared to their pure tone average. Some of them will have normal hearing, and of course the diagnosis is made by MRI. And the way we manage them there's a lot of factors that go into deciding what we're going to do to treat if they have a vestibular schwannoma. Many of them we can watch, some we take out. It's rare here, but other places they use a lot of radiation to treat them. The important thing I think for the patient to realize is even if you treat the tumor, it doesn't mean they're going to get rid of their tinnitus. So if they're really bothered by their tinnitus, it's important to let them know that what we're doing here is probably not going to make their hearing loss any better. They're not going to get better hearing by removing the tumor, and they're not going to get, you might be able to preserve their hearing, but you're not going to make it better, and you may make it worse, and the same with their tinnitus. These are some examples of different vestibular schwannomas. This is a tiny little one. This is one where a patient their only symptom may be unilateral tinnitus, and you can see that small lesion just at the aperture of the internal auditory canal, and then these are different size. So this is kind of a medium. This is a larger one. This one actually had been previously resected by some neurosurgeons and then grew back, and this is another example of a larger, where it's compressing the brainstem enough to almost occlude the fourth ventricle. There's other things that can cause besides vestibular schwannoma. So there's lots of other pathologies that can potentially cause tinnitus. This is a patient, she was a young woman from north of Cedar Rapids who had unilateral tinnitus and a very, very, very asymmetric hearing. I mean, very slight asymmetry on her hearing loss. And I waffled whether or not I thought it was worth getting an MRI. And then she popped up with this meningioma. These are lipomas, epidermoids, and these are just different types. Endolymphatic sac tumors are rare. Neurofibromatosis 2, which is devastating because you get bilateral vestibular schwannomas along with multiple other intracranial tumors. This is one where you might think that they have neurofibromatosis because they have bilateral lesions in their internal auditory canal, but the difference is they're small lesions. They're not looking sort of mass-like. They're sort of following along the nerves, and she's deaf. These are too big to cause deafness in both ears. And so this was a metastatic lymphoma. So sometimes you can have metastatic disease to your internal auditory canals. Glomus tumors or paragangliomas, these are these vascular tumors that can occur either in the middle ear or the jugular foramen, and their first symptom is almost always universally pulsatile tinnitus. They hear their heartbeat before anything else. Now, sometimes they don't do anything about it, and they come in and they have a big mass, but their first symptom, if you trace them back, would have been pulsatile tinnitus. And removal of the tumor usually improves or gets rid of their tinnitus. And this is just one example of a glomus jugulare, where you have this vascular mass in the jugular foramen at the base of the skull that's eroding. On the CAT scan, you can see it's kind of eroding the skull base in the jugular foramen. So the other thing that can cause pulsatile tinnitus, I've sort of talked about this already a little bit, these dural arterial venous fistulas. This is an abnormal connection, again, by dura we mean the bag of water, or the sac that holds in your brain water. So your brain is, and your spinal cord are encased in this water, cerebral spinal fluid. And you have to have this really tough sac that encases that. And within that sac, you can have a connection between blood vessels and veins where you have this high flow system going on. And they almost always have pulsatile tinnitus, and you can hear it. And they have a risk of intracranial hemorrhage. If it ruptures, they have a massive, profound head bleed that's at risk of killing them. And so, again, it's made by the diagnosis. If someone has unilateral pulsatile tinnitus, this is another reason why we get imaging, is to exclude this. And then depending on what it is, this is an example of that sort of system. So you see the arterial phase, and then you see this sort of just flushing of blood during the arterial phase out into this area, which you shouldn't see. This is another example here where you see, here's the arterial phase, where you see this blush of blood. This is the venous phase, and you see this blush of blood outside the vessels. And then I've already talked about this one, so we don't need to spend much time with it. Young obese or middle-aged obese women are at higher risk, and it's due to idiopathic elevation of the cerebral spinal fluid pressure. And they can have pulsatile tinnitus. Sometimes they'll have headaches. The most important thing is to diagnose it so they can have their vision checked, because they are a little bit at risk of losing their vision if they get pressure on their optic nerve, which is an extension of the brain. Myoclonus, or spasm of the muscles around the ear. Usually this is not stapedial myoclonus, but sometimes it could be. More commonly, it'll be palatal or sort of your tensor muscles that go to the malleus. So they get this very rhythmic sort of popping, snapping tinnitus. It's faster than their heartbeat typically. So it's more of a almost like a machine gun, to kind of pop, 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 pop. It's much more quick than their heartbeat. Often the heartbeat one's more about shoo, 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 shoo. And this is more about pop, 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 pop. And usually we can detect it when we watch the palate, either looking through the mouth or using a scope. Sometimes you can detect it on impedance audiometry. Normally we just try and get them to, say this is not that, if they're not too bothered by it, we try and get them to just watch it. You can give them Tegretol, which is an anti-seizure medication. You could also give them Botox, especially if it's in the palate. It's reasonable to inject Botox in the palate, which gives you temporary paralysis of the muscles. And so you could try that. It has to be repeated every 3 to 6 months. Rarely, you might go in and cut the tendon. We really don't cut the muscles, but we'll often cut the tendon connection, either of the tensor muscle to the malleus, or of the stapedius muscle to the stapes. So there are cases where where people have work-related injuries or other accident-related injuries, and so there are occasionally where legal issues arise with tinnitus. It's very difficult to sort of document and prove and figure out exactly how much their tinnitus is. You need a hearing test, and these are sort of difficult issues. The patients can be quite bothered by it, and so it can be a big problem, but they can also have other incentives to sort of play it up a little bit. So you really have to, it's a more difficult thing to sort of sort out because they're incentivized. So what about management? Rich said I was going to tell you how to manage tinnitus. Well, we don't have a lot. Cochlear implants, we don't use cochlear implants to treat tinnitus, but they are quite effective, and so I assume you'll discuss that. So cochlear implants are effective, and in fact, the original, for many years we didn't use cochlear implants for single-sided deafness, and then a group in Belgium started to do that. They had some really good results, not only with treating the tinnitus. These were a group of patients with single-sided deafness and just disabling tinnitus, and they gave them cochlear implants. And they did pretty well from a hearing perspective, in addition to having their tinnitus relieved. So now in America, several centers are using cochlear implants for single-sided deafness. And one of the motivations of the patients to get them is sometimes they'll say, well, I could use a cross-hearing aid, I could use a Baha, or I could use a cochlear implant. And sometimes their deciding factor is the implant might help my tinnitus, so I'm going to go for that option. It's hard to get insurance to cover that. Antibiotics are a medical treatment, and so if people have ear infections, we use antibiotics. If people have some types of inner ear hearing loss, so a sudden sensory nerve hearing loss, an autoimmune disease, or Meniere's disease, steroids are actually pretty effective. Now, they aren't always effective in the long term for some of these diseases. They are very effective for sudden hearing loss, for autoimmune, and somewhat effective for Meniere's disease. But in terms of just therapy targeted at the tinnitus itself, so you're not trying to treat their hearing loss. So all those other things I was talking about are treatments that we give for the hearing loss that can impact their tinnitus. We really don't have a pharmacological treatment for tinnitus, as you're well aware. And so that it's really important that people do very well designed. Because it's a subjective symptom, you have to have very rigorous and well-designed clinical trials. The other thing that's important is to just recognize that tinnitus is often associated with depression, anxiety, other psychiatric issues. And they can blame their depression or their anxiety on their tinnitus sometimes. And it's always the chicken or the egg, which is first. Are they bothered by it because they're anxious, or is the tinnitus causing their anxiety? But either way, treating their anxiety or treating their tinnitus, either pharmacologically or with counseling or whatever, or treating their depression, will have an improvement not only on their tinnitus, but on their quality of life. So it's important to realize that tinnitus is one of the manifestations or associations with these other illnesses. So just a brief summary, a very small minority of tinnitus patients will have a potentially bad problem. Acoustic neuroma, glomus tumor, arterial venous malformation, and those need to be evaluated medically. Now, most people don't have that, and so sometimes the medical evaluation is more of a reassurance to them than it is sort of a diagnostic sort of thing. There's really no proven medical or surgical therapy for the vast majority of people who suffer from tinnitus, but we're very optimistic that groups like you and those of you who investigate this and those who are dealing with things at the molecular and cellular level can come up with different drugs, things that affect glutamate transmission, prevention of ototoxic, electrical stimulation, regeneration of the hair cells, restoration of hair cell function, stem cells, other things that are being looked at. Some of these are, sort of pie in the sky, decades away sort of therapies, but we're optimistic that at some point we may have something better than what we offer now. So we're optimistic. So thank you very much. I'd be happy to answer any questions.